Thank you, everyone, for being here. And thank you to our sponsors, Tev and Norcrin. So my name is Jerry Vidente. I'm a movement disorders neurologist, and we're going to talk about tardive dyskinesias today. So something different. Usually we talk about Parkinson's, but today we're going to talk about something different. So when we get prescribed medicines, um, for whatever reason, whether it be for tremors or Parkinson's or migraines or nausea or seizures or whatnot, some of these medicines we take or are prescribed may cause some movement disorders. And we refer to these movement disorders as being drug induced, or sometimes we use the term extrapyramidal syndrome. In some of the movements that are a result of these drugs can develop, within a few hours or maybe a few days, and we call this acute movement disorders or drug-induced movement disorders. And yet, there are some drugs that will cause a movement disorder after you take the drug for about 1 to 4 weeks. So we call this subacute onset of movement disorders. And then there are some drugs where it takes a while. You seem to be okay for the first few weeks. And then after a month, maybe 3 months, maybe 6 months, maybe years after, uh, then you develop a certain movement disorder. And we call this chronic onset. And in in this particular seminar, we're going to talk about something that develops chronically after taking psychiatric medications most commonly, and this is tardive dyskinesias. So tardive, everybody knows what tardive means, right? It means late, so late onset. So it takes usually about 3 months or more. Although in clinical experience, most of these drugs that cause tardive movement disorders or tardive dyskinesias take 1 or more years to develop. And so it's not something that develops overnight. It's not something that develops after a few hours or a few days. It takes a while. So you have this sense of assurance in the beginning that, okay, the drug's gonna be fine. I'm not sleepy. I'm not dizzy. It's not making my blood pressure drop. It seems to be okay. And then years after or months after, you develop a movement disorder. Slowly creeps up on you. And the term we use for this is tardive. And then dyskinesias means excessive movements, or sometimes we use the term hyperkinesia or hyperkinetic movement disorder. So when we talk about tardive dyskinesias, we're not only talking about one kind of movement disorder. We're talking about different kinds of movement disorders. The most common of which is chorea. So chorea means fidgeting. It means squirming. It means you have some dancing movements. You're restless. So this kind of movement disorder is referred to as chorea. And also less commonly we see what's called dystonia, tardive dystonia. So I'll show you some examples later on. But tardive dystonia refers to twisting or spasming or posturing. And yet some patients of mine present just with tremor. And we refer to this as tardive tremor. So all they have is a little bit of shaking of different parts of their body, the most common of which would be their hands. And yet, I also have some patients that develop only tardive Parkinsonism. So they look like they have Parkinson's disease. In fact, they're diagnosed as suffering from Parkinson's disease, when in fact we know that their movements are related to a drug, usually for psychiatry, that they took. And then years after, they develop this Parkinsonism that looks like Parkinson's. Then we do, $1 million workup for Parkinson's. We throw Parkinson's medicines at them, and they don't respond. And the tests for Parkinson's are negative. So we know this is tardive in nature, tardive Parkinsonism. And then there's tardive myoclonus. So tardive myoclonus refers to jerking. And again, I'm going to show you some samples later on. And then less commonly, we see patients with a presentation very similar to Tourette's. Has anyone seen anyone or know anyone with Tourette's? They're the ones with tics, and they're huffing and puffing, they're producing sounds, and they're doing all sorts of tick-like movements and mannerisms. And sometimes this may be a result of the drugs that we prescribe as well. And we refer to this as tardive tics or tardive Touretteism. And then I'm going to show you an example later on somebody who just looks restless. They just can't keep still. We refer to this as akathisia. And then lastly, the least common of which is stereotypy. These are movements which are repetitive, and they're stereotypic. They do the same thing over and over. It's completely purposeless or useless, and yet they're driven to do these movements. And then the most common combination we see is a combination of Korean Parkinsonism in about one third of patients. So the $1 million question is, which drugs can cause tardive dyskinesias? So in general, the class of drugs that will cause this will be the dopamine D2 blockers, and I uh, separated them into two big classes. The big class would be the antipsychotic drugs or the so-called neuroleptics. And then the second big bucket would be the anti-nausea medication. So when it comes to the neuroleptics, so there's two big buckets again, the so-called typical neuroleptics or antipsychotic drugs and the atypical. So the typical are the old ones, right? And we less often use these drugs nowadays, but they're still being prescribed though, but less often. And these are very strong D2 blockers. They bind to the D2 receptors, the dopamine receptors in your brain, and they bind to the receptors quite strongly, and they stay, bound to these receptors, and therefore their potential to cause movement disorders is quite robust. So these are some of the drugs in this class, like haloperidol, chlorpromazine, thioridazine, and flufenazine. And the more common drugs that are being prescribed nowadays are the so-called atypical neuroleptics or atypical antipsychotic drugs. Now, these are the ones that are being prescribed not only for psychosis, they're also being prescribed for depression, very commonly, for anxiety, for OCD, for bipolar disorder. And you will recognize some of these drugs in this list because they're very commonly prescribed, like risperidone, olanzapine, aripiprazole, which is abilify, lurasidone, ziprasidone, quetiapine, cariprazine, paliperidone, and clozapine. So these are the so-called atypical. They're weaker D2 blockers. They bind to the D2 receptors less strongly, and they dissociate quite quickly, and therefore their potential to cause tardive dyskinesia will be less, but not zero. And then let's not forget the anti-nausea medicines. Like for instance, if you end up in the ER and you're throwing up, and for whatever cause, maybe you have a GI bug. What is the most common drug that they prescribe for nausea? It's metoclopramide. It's Reglan. Most of us would have tried Reglan at some point in our lives, and we know that this is also a D2 blocker, and it can cause movement disorders like tardive dyskinesias with chronic use. And then in the migraine arena, very commonly, if you have migraines, aside from there a migraine drug, they give you an anti-nausea medicine, most commonly either promethazine or fluchlorperazine. Again, if you use this chronically, this can lead to tardive dyskinesias. And then less commonly, there are these so-called non-dopamine blockers, which can cause TD. And this is a controversial topic because the question is, if they're not blocking dopamine blockers, why are they causing TD? So in this class of drugs would be antidepressants, anti-anxiety, one anti-anxiety medication, lithium, which is very, very commonly used for bipolar disorder. There's levetiracetam, which is Keppra. It is probably the most common drug now that's being used if you end up in the ER with seizures, or if you're in the hospital with seizures and they want to stop it, they'll probably prescribe you Keppra. And then there's calcium channel blockers. And these two ones are not available in the US. They're flunarizine and cinnarizine. These are more commonly used not as blood pressure medications, but they're used for vertigo. They're quite effective for vertigo, to be honest. And so this is a controversial topic about whether this class of drugs truly cause TD on their own, or whether the reason why they cause TD is because the patients have been exposed to some D2 blocker in the past. And if you really examine the histories of these patients that take this, so-called non-dopamine blockers, and they develop a TD-like syndrome, question is it really these drugs that are the culprit? And in about 90% or more of cases, I would say, most of these patients that are exposed to these drugs and develop TD would have been exposed to another dopamine blocker in the previous class of drugs we just talked about in the past, or they are also concurrently taking one of these drugs. So in other words, if you're taking a dopamine blocker, you don't have TD, and then somebody else, prescribes you an antidepressant and adds it to the mix, chances are, The two together will enhance your tendency to have TD movements or tardive dyskinesias versus just being on just the dopamine blocker by itself or the antidepressant by itself. But just be aware of this. Okay, so given that the antipsychotic drugs, almost all of them, if not all of them, have the potential to cause TD, which drugs have the least potential for causing tardive dyskinesia? There's only two in my mind. These are clozapine and quetiapine. But even these two, there are reports, rare reports of tardive dyskinesia. So you're not out of the woods perfectly. But if I were to choose, within the less of all these evils, which one would I probably choose so that the chances of TD will be minimized? It's going to be one of these two. Now, quetiapine very commonly prescribed. Even as neurologists, we love this drug. We use it for hallucinations. We use it for delusions, even in our Parkinson's population. It's one of those drugs that we feel very comfortable prescribing, and we feel like, okay, it's not going to cause worsening of the Parkinsonism. Most likely, will not cause tardive dyskinesias, except if you use whopping doses. So, as neurologists, we're comfortable using maybe 25 to 100 milligrams of quetiapine, quite a low dose, where psychiatrists tend to push this up and higher, mainly for whatever reason, for psychosis or bad depression or bad uh, um, mood disorder, in which case the higher doses, usually 200 milligrams or more, are the ones associated, more highly associated, I should say, with tardive dyskinesias. And then clozapine, well, boy, this is a pain in the butt to prescribe, to be honest, because it causes suppression of your bone marrow and causes a drop in your white blood cell count. So obviously, you're not going to be you're going to be more prone to infections. You need your white cells, the WBCs, to fight infections. So if that is suppressed or reduced, that's probably not a good thing, right? You'll be more prone to infections. So why are we talking about TD? Because it is more frequent than we think it is. In fact, the estimate is anywhere between 600,000 to 1 million cases in the US. Now, just to put things in perspective, we talk about, everybody knows somebody or lives with somebody with Parkinson's, right? Or an acquaintance or a celebrity or somebody in your church that has Parkinson's disease. Dime a dozen. How frequent is Parkinson's in the US? Estimate is about 1 million. So tardive dyskinesia is not something to sneeze at, right? If the estimate is 600,000 to 1 million, it is not too far away from some movement disorder that everybody knows about, which is Parkinson's disease, right? And yet, and here's the sad part, whereas almost everybody, including your primary care, can recognize and can make a correct diagnosis of Parkinson's and put you on the right road with the correct medications, only about 15% of tardive dyskinesia patients are accurately diagnosed. They're diagnosed as something else. They're diagnosed as being restless. They're diagnosed as being anxious. They're diagnosed as having mannerisms or tics or whatever. And therefore, they're never diagnosed correctly till many years after when somebody who has, I've seen this, I've seen many of these patients, I recognize this, and therefore I will diagnose this correctly as tardive dyskinesia. Okay, so that percent is unfortunately only 15%. And so we doctors have to do a better job in educating ourselves in terms of recognizing this so that we can put our patients on the right track and not make them go different ways before they finally are on the right road to the right treatment regimens. Now, what is the prevalence? So prevalence would be about 20%. What does that mean? Average. So if I start you on a neuroleptic, so for instance, if there are 100,000, let's say just for the sake of discussion, 100,000 patients on neuroleptics in the US, what percent of that 100,000 will develop tardive dyskinesias? It's 20% on average. It ranges from 7 to 50% depending on which dopamine blocker you're talking about. If you're using the typical neuroleptics, it's higher. Why? Because they're stronger and more ferocious D2 blockers. Whereas the newer ones, the atypicals, are weaker D2 blockers, and therefore the prevalence would be lower. So The choice is, I mean, the choice is obvious, right? If you were to be put on a neuroleptic for whatever reason, obviously the atypical neuroleptics will be the best. What about incidence, and what does that mean? So, for instance, I start you on a neuroleptic today. So, in the first year, if you were taking one of the typical neuroleptics, you have a 7% chance on the first year of develop by the end of the first year of developing tardive dyskinesia. By the second year, it's 14%. By the third year, it's 21%, right? It's cumulative. This is what you mean by incidence. Per year, what percent will convert to new onset diagnosed tardive dyskinesias? Okay, that would be 7% per year. What about the atypicals? It is lower. It's about 3%. Again, so what does that mean? So if I start you, for instance, on risperidone today, which is a very probably the most commonly prescribed atypical neuroleptic in the US. So the first year, by the end of the first year, you have a 3% chance of developing TD. By the end of the second year, it's going to be 6%. Good job. By the third year, it is 9%. See, easy peasy. Everybody can do math. So, so again, so the longer, it's so obvious, the longer you are on a neuroleptic, the higher the chances that you will develop TD. So this is kind of a weird class of drugs. It's most of the time when we doctors prescribe a drug, we say, "Oh, it's been 6 months. You have nothing. You have developed nothing. You must be okay. You'll tolerate this drug. You're out of the woods. Easy peasy. Everybody's happy." Not this class of drugs. We have to be careful about this class of drugs because the longer you are on these drugs, right, the higher the chances that you will be out of the radar, right? That nobody's going to be paying attention. Nobody will be vigilant about monitoring for some side effect. And then boom, years after you develop a movement disorder and nobody's kind of paying attention, and nobody even knows what's going on. When in fact it was that, that risperidone that was started by somebody 10 years ago. And you were just taking it and you kind of say, well, it couldn't be the risperidone. I've been on this for 10 years, right? Well, yeah, it is because it's one of those Tardive movement disorders. Remember, Tardive means late. It's not in the beginning. It's not a few days or weeks after. It's months to years after. Okay, so now we know the prevalence. Now we know it's a common condition. Now we know what kind of drugs will cause this. Now, who are more prone to developing TD? So this is more or less a list of who are at risk. So the higher the dose of the neuroleptic, the higher the risk for TD. The stronger the neuroleptic, the typicals, right? We discussed this already, the higher the chances of TD. The longer duration of use, the higher the chances of TD. If you combine drugs, like remember what I mentioned a while ago, you combine a neuroleptic, an antidepressant, then another one, and an anti-anxiety medicine. So the more there are in the mix, the higher the chances of TD as well. And then elderly females, we're particularly careful about elderly females because they are more prone to developing TD. And then what about ethnicity? The Afro-American ethnicity seems to be more prone to developing this. And then those with dementia or cognitive impairment, those with the history of stroke, those with underlying Parkinson's disease or some atypical Parkinsonism, they are more prone to developing tardive dyskinesias down the road. Those with a mood disorder, those with negative schizophrenia symptoms, those with alcohol or drug abuse, and those with diabetes, especially bad diabetes. Okay, so here's an example of classic oral buccal dyskinesia. So pay attention to the mouth. Okay, this is the classic presentation of oral buccal dyskinesia. This is textbook classic. This is medical school, uh, 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 bit of information that we're taught as students. If you want to diagnose TD, look for this. Look for this so-called oral buccal dyskinesias. But here's the but. We only see this in 72% of cases. So if we're not looking elsewhere, we're going to miss the diagnosis. Yes, if it presents classically like this, it's easy peasy, right? And if it's as obvious as this, it's easy peasy as well. But look at this though. This is quite subtle. Pay attention to the mouth right there. There's just a little bit of pursing, right? It says, I mean, all of us can do this, right? I can do this. It could be a mannerism, could be a gesture, whatever. or just a little bit of restlessness. But if you don't pay attention to this, if I, a doctor, don't have my eyes peeled and I'm not, sharp, I'll probably say, oh, I don't know what that is. Just a little bit of fidgeting around your mouth. Maybe I don't know. Maybe you have some dental caries or done some dental issues or whatnot. When in fact, this is subtle lip pursing and early signs of tardive dyskinesias. Okay, now this is a isolated blepharospasm. Just look at the eyelids right there. They're kind of squinty, right? And some of these patients have frank spasms like this. Their eyes were really closed, and it's difficult for them to open their eyes. They get very photosensitive. The bright light just triggers this. This is called blepharospasm. It's eyelid spasms. And then there's cervical dystonia. Pay attention to the neck. It twists towards one side. And I see cases of this, just isolated cervical dystonia as a manifestation of tardive movement disorder. And we refer to this as tardive dystonia, right? Dystonia of the neck. Okay, what about the jaw? Look at this. What is she doing? She has this, kind of moving, side to side of the jaw right here. Quite subtle, can be easily missed. And then this is more obvious. When she talks, which direction does her jaw go? It goes that way, right? It goes to the right. Exactly. So this is lateral jaw deviation, which again we can see in tardive dyskinesias. This one is so obvious, right? This is jaw opening dystonia. So the jaw opens or drops involuntarily, obviously. And he also has some blepharospasm and spasms of the eyelids in the upper face. Okay, what's happening here? She's trying to talk. Did you see this? That's the masseter. That's your chewing muscle. That's the muscle that closes your mouth. That's the muscle you need to chew on your steak, right? Okay, when you chew, it's a masseter right here. Okay, so imagine yourself. Okay, everybody, bite on your masseter. Okay, not try talking. Okay, see what I mean? Okay, so if your masseters are dystonic like this, okay, it will be difficult to chew, difficult to eat, right? And difficult to speak, right? Okay, so this is again something we see that can be related to tardive dyskinesias. This one is more common in more advanced TD. I call it the flycatcher's tongue. Tongue keeps darting in and out like this. The darting tongue. But again, you don't go overnight from normal to this. This will take months or even not years to develop. It'll be sometimes just some movements of the tongue when you make them open their tongue. Like for instance, this particular chap, had tongue dystonia. I had to make him open the mouth, and you see the tongue go sideways like this. It goes to the left in this case. So this is tongue dystonia. If I don't make him open his mouth, I won't see anything. Which is when I examine patients, first I look at them with their mouth closed, and then I make them open their mouth, and then I make them stick out their tongue. And this is how I look for movement disorders, including tardive dyskinesias, involving the tongue. Now, rarely it can affect the vocal cords. So the vocal cords or the larynx can develop dystonia, and there's two types. One is called the adductor type. They sound strangulated like this. That's adductor spasmodic dysphonia. Whereas the other one is very breathy. They have a breathy bathroom voice like this. Okay, that's the abductor spasmodic dysphonia. Okay, having educated you, you tell me what kind of spasmodic dysphonia this is.
My grandfather, you wish no, my grandfather. Well, in here near 993 years old.
Okay, which one is that? Is that the strangulated type or the breathy type? Strangulated. You guys are so smart. Okay, so this is the adductor type of spasmodic dysphonia. And then we see very commonly as the tardive dyskinesia becomes worse, MEJ. MEJ means you have eyelid spasms and mid or lower facial and even tongue dyskinesias. That's called MEJ. Okay? And then MEJ is not unique to tardive syndromes. We see this as idiopathic, meaning no cause. Sometimes we see this from strokes. Sometimes we even see this associated with Parkinson's syndromes. But in most of the cases of MEG I have in my practice are just idiopathic. We don't know, and some can be genetic, genetic dystonia syndromes. And this is somebody with upper limb dyskinesias as part of the Tardive syndrome. So pay attention to those fingers and the arms. There, she can't keep still. She also has dyskinesia of those legs. And then this is very subtle Tardive chorea of the fingers. Again, this can easily be missed by your doctor. That's why when I see my patients and they kind of want to, come literally face to face with me, I said, no, I need you rare there, far back. And so if you go to my office, your chair is gonna be about 6 feet away from me because while we're talking, I want to pay attention to your face, your neck, your arms, your fingers, your legs, your toes. I want to see everything while you're talking and giving me your history. Because while you're giving me your history, I'm already doing the exam. I'm already paying attention to those little details, including your fingers. And if I see your fingers go like this lady that was taking some neuroleptics. Like, wow, okay, that looks like the early signs of tardive dyskinesia. See, very easy to miss. And mind you, this lady had no oral buccal dyskinesias. Remember what I said? Only 72% have the oral buccal dyskinesias. The rest do not have it. And therefore, your doctor will miss this if it presents in the fingers first. Okay, here's somebody with leg or lower limb dyskinesias. Okay, she's kind of doing that. I tell her, don't move. And she's trying her best. Oh, she's really trying her best. And yet those legs will just jiggle and move. And then I make them take off their shoes. Sometimes, I don't see those leg dyskinesias I just showed you. I see these very subtle, movements of those toes. They're just like wiggling like this. Now, mind you, there's an interesting condition called painful legs moving toes. Painful legs moving toes. I see this in patients with bad neuropathy. They have burning feet. Their feet are painful. They probably have diabetes or some cause of neuropathy. And then when I see them, their toes are going like this as well. So the differential for me when I see those toes going like this in my office, and if they say, yeah, those toes burn, okay, that's painful legs moving toes. That's probably a neuropathy. Let's do a nerve test or an EMG to see what's going on. As against this, patient has no symptoms of sensory symptoms, no burning, no pain in the feet, and yet she tells me, oh wow, I can't wear closed shoes anymore because my toes keep wiggling and jiggling. I just have to wear my sandals. And so when I see this, I say, okay, let's look at your list of medicines. Let's see whether somebody has prescribed you a dopamine blocker. Okay, this is somebody with tardive dyskinesia. As you can see, the arms flapping like this. But what I want to show you is, he will go side view in a second. You tell me what's happening. Boom. Yeah, she's bending backwards. Okay, this is truncal dystonia. Again, this is part of a Tardive syndrome. Sometimes we call this, sometimes we see patients that instead of bending backwards, they bend sideways like this. And when we see that, when there's truncal deviation, usually sideways, we refer to this as the PISA syndrome, right? You know why we call it the PISA syndrome? Of course, Tower of Pisa. Absolutely, the Tower of Pisa. It's leaning, right? And that's exactly why we call this the Pisa syndrome. So when I see the Pisa syndrome or truncal dystonia, and patient doesn't tell me anything else except that, what is the first question I ask them? Did anyone prescribe you a psychiatric medication or anti-nausea medicine in the past? And they say yes. Okay, let's take a look at your list. Okay, and then I can say, there you go. This is Pisa syndrome related to your neuroleptic. Now, this is quite subtle. This was published by Sharma et al. In a very famous, prominent journal in 2020. You see the pelvic thrusting like this, and some think that this is quite typical of tardive dyskinesia. Again, I don't see tardive dyskinesia of his mouth like here. I don't see any, right? And yet he has this pelvic thrusting. And this is again a rare manifestation and yet quite typical manifestation of tardive dyskinesia. So when I see this, they're kind of doing the hula hoop, so to speak, in my office like this. Right? I said, "Can you stop doing that?" And they said, "No, I can't stop it. It's just doing it." And usually when patients are in my office, they suppress the movements. And what do? I distract them. I distract them. I say, "Oh, can you count from 100 backwards in threes?" And they're very still, right? And then now I stress them out. Now, oh my God, when was the last time I did my math? Okay, 197, and now you see all the movements and the jiggling. I call that distraction. So I distract their mind so that they're now not consciously suppressing this movement disorder. And therefore, the movement disorder just comes out, and there you go. Aha, I caught you. There you have it. This is exactly what it is, and this is how we're gonna treat this. This is what I was referring to as somebody with a Tourette's-like syndrome. So usually with the Tourette's, they have jerky movements. They're doing this, they're grimacing, and they're producing sounds, and some of them even curse. You know, that's called coprolalia. They say "f you," right, in my office, in front of me. Yeah, imagine that. And yet, it's a form of a vocal tic. And sometimes we see this tic-like or Tourette's-like picture because of a neuroleptic. Usually, Tourette's, we see this in children. We see this in adolescents or young adults at the most. But it's rare when we see this in the elderly or middle age, and then it starts. And then when it starts in middle age or you're past 20, I kind of say, "Oh, that you're too old for Tourette's." Uh, Usually, Tourette's, you have to be about 18 or less for the onset before I can say, "Yep, that's Tourette's." You have the motor tics, you have the vocal tics, you're cursing, and you can suppress it. And you have an urge, you feel good when you do these tics. So it must be tics or Tourette's, except if you're too old. Okay, this is what I'm referring to as the akathisia, restlessness. They're just restless. They just can't keep still. This individual, he was doing this all throughout my 1 hour of interviewing him. He said, I said, "Can you just sit?" He said, "No, I can't. I'm just restless. I can't sit. I'm gonna explode inside of me if you make me sit. I have to stand up. I have to move." Okay, that's called akathisia. It is an irresistible urge to move. And sometimes we call this, although it's a voluntary manifestation, right? I choose what I do, right? It's voluntary. But usually we use the term semi-voluntary or involuntary. Okay, semi or involuntary for this kind of movements where it is so irresistible, you've got to do it. Okay, so this can be a manifestation again of the neuroleptics that we use. And then this is stereotypy. The most common stereotypy, which is a repetitive, useless, purposeless movement, is just marching in place. They march like this. They march, 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 march. And again, this is a nun I saw many, 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 many years ago after my fellowship in movement disorders, and she was just marching and marching there in my office, and she couldn't keep still either. She needed to do this and stand and keep standing and just do this stereotypic purposeless movement. Some of this can be rocking. Another stereotype I see is rocking like this. They just keep on rocking. They're in their chair in front of me and they're rocking and rocking and rocking. It's like, "Can you stop rocking?" No, I can't stop rocking. It's just I just gotta do this thing. Okay, so that's they're driven to do this stereotypic movements or stereotypies. And if there's a neuroleptic in the history, then I say, "Yep, that's Tardive in nature." Okay, this appears like tremor, but it's very jerky. It's like jerky. Tremor, like it looks like this, rhythmic. Okay, whereas a jerky movement like this that looks like a tremor is myoclonus, and this is an example of Tardive myoclonus, but misdiagnosed as tremor. And then this is somebody with Tardive Parkinsonism. Remember, I mentioned a while ago, some of my patients look like they have Parkinson's disease, when in fact, they do have, a Tardive tremor or Parkinsonism syndrome. Again, related to some dopamine blocker that they were prescribed in the past. Now, how do I know they don't have Parkinson's? Because they don't respond to the Parkinson's medicine. That's one. And then I do a dopamine scan or DAT scan that's negative. I can even do a skin biopsy for Parkinson's for this patient, looking for alpha synuclein, and that's negative as well. So there's no features that are positive that we usually look for Parkinson's disease. And then this usually develops months, if not years, after taking a neuroleptic, and they respond to the medicines that we usually prescribe for tardive dyskinesia. So I know this is tardive Parkinsonism. Okay, so here's this $64,000 question. Once you have tardive dyskinesia, is it reversible? Right? So everybody asked me this question in my office. How do we fix this thing and how can we reverse it? Now, if the drug is not discontinued because your psychiatrist says, "Oh no, this individual will have a psychiatric breakdown, has been in the psychiatric facility multiple times. There is no way, Jose, I'm going to stop that drug because the patient will be in danger of this and to himself or herself and to the family and society in general. No, I'm not going to do it. Fine. So if the drug is not discontinued, there's a 2.5% per year chance of remitting. Small but possible. Okay, but I'd say, okay, if you get lucky, it's like winning the lottery. Sure, let's do it. Okay, but if the drug is discontinued, is it a lot better? Well, here's the sad thing. One study showed that only 12% will remit in 7 years. Now, that's not that's not a lot better than 2.5% per year, is it, right? I mean, if I multiply 2.5% per year times 7, that's even more than the 12%. From stopping the drug. So stopping the drug really doesn't, make the tardive dyskinesias remit any more, although some studies seem to suggest it does, but some studies say, nope, it doesn't. So now, for instance, in one study of 54 patients, they followed them for 8.5 years. If you stop the drug, there's a 22% chance of remission. If you don't stop the drug, it's 5.8. So there might be a chance if you stop the drug, but with a price to pay, right? If you stop the drug and you don't replace it with another effective drug, what happens? Then poor patient and poor psychiatrist will be, pulling their hair out trying to find a solution for their bad psychosis or bad mood disorder. But the bottom line is this: the longer the duration of exposure, the less the chance of reversal. So it's never too late to act. Okay, in terms of should I stop this or before tardive dyskinesia comes out, or if I do, uh, if I really want to take my chances, the earlier you stop the offending drug, the higher the chances that it may remit. Now, if I notice the beginning of TD, should I stop my neuroleptic? And this is where sometimes it pains me when the patient comes to my office and says, you know what, I didn't even tell my psychiatrist. I kind of saw this in TV and in the internet, so I stopped the drug by myself. I said, oh darn it, don't do that, right? So don't just stop the neuroleptic. And in fact, sometimes we see what's called withdrawal emergent dyskinesias. These are tardive-like movements that come out because you stop the drug. It's a withdrawal. It's like if you're an alcoholic, right? For 20 years, then I kind of say, oh, okay, I'm gonna keep the keys to all the booze in the house. And then what's gonna happen to you? Wow, poor you. You're gonna go into withdrawal syndrome. Or what if you were taking, let's say, clonazepam, which is a very or some benzodiazepine like Xanax for many many years, and then suddenly because of the regulations and cutting back and Big Brother looking over your prescription, the controlled substance, somebody you have a new primary care and your new primary care says, no, I'm not gonna renew your Xanax. No, I'm not gonna do it. Poor you, you're gonna go into a withdrawal syndrome, right? If nobody tapers you down slowly. Same thing can happen with the neuroleptics. You can develop de novo dyskinesias just by stopping it. So you even made it worse. So usually when we want to stop, when you want to stop, we taper or we substitute with something else. Or better yet, we start you on a VMAT2 inhibitor to tackle the dyskinesias, which we're going to discuss later on. So what are the most recommended regimens when tardive dyskinesia is now recognized? Now, mind you, when we see and we rate patients with tardive dyskinesias and we say, it looks mild to me, and yet when a study was done of these patients with tardive dyskinesias and they were asked, okay, how does the TD affect you in your life, psychiatrically, physically, socially, your employment, how will this TD affect you? Even those mild movements, about three-fourths of patients will say, yeah, this has a big impact on my life. So even the mild movements can have a big impact, which is why, as a physician nowadays, I ask, even if I say, well, you have a little bit of, fidgeting of your fingers and your toes are going like this every now and then. I see your mouth, go like this. And then I say, it's kind of mild. And should we really treat it? If the patient says, yeah, I want to get rid of this. This is embarrassing. I don't want to look, restless and fidgety. I don't want people to be staring at me and my mouth going like this, even if it's mild to you. Okay, fine. The moment that patient tells me it bothers them, I treat. Okay. So I treat the patient and the disability that the patient feels, not what I rate as being mild, moderate, or severe. Okay, so first things first. I removed the anticholinergic drug, and there's three drugs most commonly: cogentin, benztropine, trihexyphenidyl, which are commonly prescribed co-prescribe with your neuroleptic. So if you're started de novo today by your psychiatrist on neuroleptic, chances are they will prescribe an anticholinergic drug. And the purpose for these drugs is to reduce the chances of an acute dystonic reaction. So usually when we start a patient on neuroleptic or increase the dose, there is a chance that they will end up in the ER and they're like a pretzel. They're dystonic like this, or their heart goes like this, or their neck goes like this. It's called an acute dystonic reaction. It happens within 24 hours to a week after a neuroleptic was started or the dose was increased. Okay, that's an acute dystonic reaction. And the chances of that happening will be less if one of these drugs is prescribed. However, that usually is more prevalent in the first 3 months. So after the first 3 months, we're supposed to get rid of these drugs, but most of the time we just keep these drugs there, and these drugs will bring out the tardive dyskinesias down the road. Okay, you're no longer prone to developing acute dystonic reactions, but now you're prone to developing tardive dyskinesias a year or more after because of the D2 blocker. And then the class of drugs that I recommend, the drugs of choice, will be the so-called VMAT2 inhibitors. And I encourage you to check out our sponsors in the back and ask them about these two VMAT2 inhibitors that I favor in the market, which are valbenazine and deutetrabenazine, which are Ingrezza and Austedo, respectively. They're both very effective in treating tardive dyskinesias. These are the first-line drugs in my practice. Now, however, there is also an older drug called tetrabenazine, which was being used for Huntington's disease. It's now generic. It's not as good as the newer ones. It causes more depression, more Parkinsonism, more sedation. But if cost is an issue, or you really don't have, the funds to cough up the copay, or you don't have any insurance, I am forced sometimes to use tetrabenazine. It works, but it's not as clean and as effective as the newer drugs called Ingrezza and Austedo, which are my drugs of choice. And then I also use amantadine, which is a flu drug, especially in those with Parkinsonism, because it hits two birds with one stone. It may help the dyskinesias. It can also help the Parkinson's, or Parkinsonism, I should say. Now, what drugs do I not recommend and yet are being used in practice by many physicians? One class of drugs will be neuroleptic. It's kind of weird. You use the same class of drug to suppress a movement that was caused by that class of drug. Isn't that weird? Right? It's kind of weird because sometimes when, let's say, for instance, I'll give you an example. What if you develop tardive dyskinesias with risperidone at 3 milligrams per day? I said, wow, wow. And then I tried to reduce it or stop it, and then suddenly your tardive dyskinesia becomes ferocious. That's a withdrawal that your physician wasn't aware of, that usually lasts for about a month. They go to withdrawal dyskinesia. So when they withdraw the drug, now you get ferocious tardive dyskinetic movements. And then I can say, oh, we're going to bring it back. Okay, so I bring it back. But this time I push it up. I say, I'm going to prescribe 4, 5, even 6 milligrams for risperidone. And then suddenly you calm down. Okay, the tardive dyskinesias for a while. There's a honeymoon period. I jack up the dose of the neuroleptic, and the TD movements will come down. Okay, that's the honeymoon period. And then later on, after a few weeks, a few months, it comes back again. And this time, even worse than before. So it's kind of weird, but the same class of drugs that will cause the TD can be used temporarily, at least, to suppress the movements. But again, I don't recommend that. Why? Why? Because you only have a honeymoon period, and after that, it bites you in the rear end. And then there's valproic acid, which is a seizure drug and also used for migraines, but it causes Parkinsonism, tremor, and weight gain. I rarely use this because it by itself, I see Parkinsonism or tremor or bad weight gain as being prominent symptoms of valproic acid. Then benzodiazepines, I don't recommend this at all. They're just sedating you. They're just calming you down. They're just making you quieter. They'll make you fuzzy, dumb, imbalanced, dizzy. It's not worthwhile. Plus the fact that these are controlled substances. And of course, there's also the muscle relaxants, which would calm non-specific, calming of all the muscles in your body. Again, side effects are very similar to the benzodiazepines. Now, here's somebody with bad jaw dystonia, but at the same time also has neck dystonia and trunk dystonia. You see that, right? I'm going to make you focus on the jaw because the jaw dystonia is so difficult to treat. It's easier for me to treat neck dystonia. It's easier for me to treat blepharospasm, but jaw dystonia is so difficult to treat with medicines or even with botulinum toxin or Botox. And yet, this particular patient, when I give him, and I discovered this many years ago, when I give him a sleeping pill called Zolpidem, okay, and this is an off-label use for this. Look what happens 1 hour after I give him Zolpidem. Everything quiets down. Okay, so this is one of my tricks for jaw dystonia. I found out this is quite effective for patients with jaw dystonia from whatever cause, whether it be stroke, whether it be tardive dyskinesias or genetic syndrome. It is quite effective for jaw dystonia, aside from generalized dystonia, which I just showed you. Mouth opens, neck to the side, eyelid spasm. So this is what we call segmental dystonia. Okay, so again, this particular individual, I started him on a VMAT2 inhibitor. Back then, there was no Ingrezza, there was no Austedo. I use tetrabenazine, and this is what happens after tetrabenazine. Quite impressive, right? It's like night and day. Exactly. This is what I mean by the VMAT2 inhibitors are the drugs of choice when it comes to tardive dyskinesias. I don't think anything will compare, to this class of drugs. They're quite impressive. Okay, what about supplements? So there's two supplements I want to highlight. There's vitamin E and ginkgo. So there's, when I was a fellow, we were already talking about vitamin E, and back then, we didn't have any of these VMAT2 inhibitors. Tetrabenazine was not available in the U.S. We in the past, some of my patients were getting it from Canada in whatever way they could. And so the only thing we could prescribe back then is vitamin E. So we load them up with high doses of vitamin E, maybe 2,000 units or above. So after many years, this was in 2022, they did a meta-analysis of 21 studies of vitamin E in 854 patients. So it's combining these 21 studies. And if you look at the data, it looks like vitamin E does reduce the dyskinesia score. This AIMS is a dyskinesia score. Every time you go to my office, I rate you with the AIMS. I give you an AIMS score. The higher, it's like 0 to 40. The higher the score, the worse. 0 is obviously my goal, right? 0 means no more dyskinesias. So it reduced the dyskinesia AIMS score by 2.36. So the clinically meaningful change is 2. So 2.36 is significant compared to controls. And then this other supplement called ginkgo biloba. This is used for stroke. We use it for memory. Okay, it's being used for memory enhancement in the U.S. It's something you get it, over the counter. Even Amazon will sell you this. So there was a 12-week double-blind study that showed that ginkgo at 240 milligrams per day does reduce the AIMS score in comparison to placebo. And then there's botulinum toxin. The problem with this is that it's given every 3 months, and you really need an expert to do this. Like, for instance, I'll give you an example of if you have eyelid spasms. I give botulinum toxin injections to the eyelids to keep your eyelids open. I also you do this for patients with Parkinson's with blepharospasm, or just plain blepharospasm for that is idiopathic. These are patients that are squinty and their eyes are spasming, they're closing, and it's a temporary relief. I have to do the shots every 3 months. Obviously, you want an expert to do this, right? You don't want any Tom, Dick, and Harry to be doing injection around your eyelids. Yeah, or somebody with a tremor, right? If your doctor has a tremor, oh my God! If you see you go to your ophthalmologist or your neurologist, and you see the doctor tremoring, and you're there for Botox injections of your eyelid, but you better run away fast, right? Okay, this is somebody with neck dystonia and a neck tremor. So how do we do the shots? Usually from the back. We do the splenius here. There's the longissimus. There's semispinatus. There's several muscles here. I use an EMG and a machine. That sound right there. That's the sound of the muscles that are tremoring, that are spasming. So the EMG machine guides me as to, okay, where are those muscles that are spasming? Where are those muscles that are tremoring? And we see this also in patients with Parkinson's or Parkinson's syndromes. Not uncommonly, I give shots for cervical dystonia or eyelid spasms in my Parkinson's patients. And this is somebody with jaw closing dystonia.
Bite, bite.
Keep
Keep
biting,
biting,
bite,
bite, keep
so
biting,
bite,
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 bite.
bite. Okay, now just relax.
Our hearing. Okay, and then if everything else fails, I recommend deep brain stimulation because it's quite effective for chorea, dystonia, tremor, Parkinsonism. And then if some patients also are not yet ready for deep brain stimulation, they want something alternative for mesh. They do, you go to your oculoplastic surgeon or ophthalmologist. They do an eyelid lift, or they cut some muscles around your eyelids, or they cut parts of the nerve. The problem with this is sometimes it comes back, or oftentimes the movement disorder comes back. And also, if there's a side effect, it is permanent. So if they cut too much of the muscles around your eyelids, or they cut a nerve that makes you feel around your eyes, it's permanent. It's irreversible. And the nice thing about deep brain stimulation is that it is perfectly reversible. So, for instance, here's somebody with medically refractory tardive dyskinesias. We tried the VMAT2 inhibitors. In fact, I tried both in the market, and she still did not get enough relief. And you see, the mouth movements. Oops. You see the mouth movements and stuff like that. And so this is somebody before deep brain stimulation, and this is her 2 years after. Big difference, right? Yeah. So it is enduring. The effect is enduring. And this is somebody with jaw and tongue dystonia. So his jaw opens, the tongue comes out. Again, I threw everything at him drug wise, and nothing was working. Okay, and this is him 3 weeks after deep brain stimulation. The effect is quite rapid with deep brain stimulation. It's the moment we find those magic settings for the stimulator, it will work. Okay, and then this is somebody with mesh with a little bit of cervical dystonia. You see the eyelid spasms over here, and then you see the mid facial and then if you do the side view, you see her head tipping backward. Okay, and then this is her 3 weeks after deep brain stimulation. Again, we threw everything at her. We were doing shots. I was doing shots on her for many years before she said before the shots stopped working. Then she said, "Wow, okay, I think I'm ready for deep brain stimulation at this point." And then it was quite dramatic for her, to be honest. It's just night and day difference. And again, the moment we find those magic settings, it really works. This is somebody with jaw dystonia. So the jaw opens, and then you see this eyelid spasm, right? You also see the noisy breathing. We sometimes see this in patients with oral buccal dyskinesias and respiratory dyskinesias. Their breathing tends to be a little noisy. And then this is him 2 weeks after deep brain stimulation. Again, quite dramatic. It's like night and day. And then this is our first patient with tardive blepharospasm that we did deep brain stimulation on. This was maybe 10 years back. And again, he works as a radiology technician. Obviously, you need your eyes to look at the X-rays, right? And and I was doing Botox injections regularly until it just stopped working. And then this is him, after deep brain stimulation. So again, night and day difference. Okay. So for those with medically refractory tardive dyskinesias, I do recommend a deep brain stimulation as an exit ramp for them because it does work. So far, we've had zero failures with this. Okay, because we choose the patients quite well and we screen them. We make sure there's no contraindications. And so far, every Tardive patient we've done has been successfully responsive to deep brain stimulation. And it's paid for by insurance. Um, or if not, we at least get pre-authorization. And then lastly, deep brain stimulation is invasive, meaning it's surgery. But there's transcranial magnetic stimulation. This is it's non-invasive. This is actually used by psychiatrists for psychiatric reasons, major depression, OCD. We also use it in the migraine arena rarely. There's a double-blind study of 26 TD patients. It showed that TMS, or transcranial magnetic stimulation, was compared to sham, and that it seems to improve the aims. Again, it's a temporary measure. It's not thing that is long that is enduring. You kind of have to do this repetitively. It's like the acupuncture. Acupuncture may help your aches and pains and whatever, or your headache or whatnot. And then you just have to do it, several times a week and week in, week out. And then there's also transcranial direct current stimulation, and this is a even smaller machine that's being used for cognitive enhancement, for depression, chronic pain, and your physiatrists or physical therapists may even use this for post-stroke patients or those with traumatic brain injury. And there was one double-blind study of 64 patients in China, and they also had some results of positive results, at least 30% improvement. Again, nothing in comparison to deep brain stimulation. It's not night and day, and this is repetitive. This will be literally maintenance therapy, and not covered by insurance, and can be quite costly, whether it be TMS or TDC.